Okay, right. So today, I don't know which one, I think 30th or so, I'm not really sure, right? Class. And so what we are going to do is today, I was asked by, I don't know, someone to do cervical cancer. There were two topics. One of them was, I think, cervical cancer. So we'll do cervical cancer, right? We'll do cervical cancer. And then we'll complete that topic because it's a very quick topic, right? In a sense, because as far as the what is this MBBS students are concerned, you do not really need to go into depth about cervical cancer, right? So what you need to know, of course, are the principles of the diagnosis and the treatment of cervical cancer, and that should be enough for you to get your full marks. Okay, right. Now, as you know, the biggest problem with cervical cancer is it starts to grow, and when the lesion starts in the cervix, normally it is in the scomocolumnar junction, right? And from there on, it spreads to the body of the cervix. It can spread to the uterus, but that does not affect the stage, right? If it spreads downwards to the uterus, that's really does not affect the stage because it is confined to the uterus only. But the cervical cancer, the problem is there is more lymphovascular invasion. It starts to go into the, because the lymphovascular or everything is around the parametrium that is supplying the cervix, right? So therefore, the tumor starts to invade into the lymphovascular invasion, right, into the parametrium. And then that happens, when that happens, right, it slowly goes along the parametrium and then it reaches the pelvic side walls. Okay. Once it reaches the pelvic side walls, then it starts to invade into the blood vessels, the ureters, right? And then from there onwards, it will spread. The chances of it having a blood borne metastasis, that is, it's spreading with the blood, is rare. So mainly cervical cancer spreads by lymphovascular invasion into the surrounding structures. So it quietly goes from there, it goes down to the vagina, right? It invades the vagina. It can go up to the uterine corpus, but that is not significant. It doesn't really make a difference. But then it spreads sideways into the parametrium and then to the pelvic side walls. Through lymphovascular invasion, it goes to the pelvic lymph nodes, and there onwards it goes to the para-aortic lymph nodes, right? So blood-borne spread is rare. What it is basically a local spread that goes to the parametrium, down to the vagina, right? And to the lymph nodes and to the pelvic side nodes, and from there onwards, then of course it spreads. Okay, you all understand? So the biggest problem with cervical cancer is that it is the commonest malignant tumor of women in the third world or developing countries. Why is it common? Because it's not diagnosed very much earlier, and because cancer is invasive, as you know, and because it's not diagnosed earlier, it ends up being a cancer. Number one. All over the world, if you take, it is the third most commonest cancer in women, right? The first usually is breast cancer, and in some countries it's skin cancer, strangely, right? Breast cancer. And then the second is usually colorectal, right? And third, normally it changes from country to country. So normally it is breast, colorectal, and then cervical cancer, third commonest cancer if you take the whole world, right? So therefore, now about what has happened to this incidence of cervical cancer in countries that have a very good call-recall system of cervical screening, the invasive cancers have gone down drastically. It has gone down very much. So therefore, they are placed in the list of malignant tumors of women have come down due to a very, very good cervical cancer screening program, right? Normally, in the countries that have able to implement this cervical cancer program, right? Cervical screening program, the rates of doing cervical screening is over 85-90%. So that means 85 to 90% of the women of the reproductive age are screened for cervical cancer, right? So therefore, what happens is very, very, very early stage, precancerous lesions are detected and treated. And even if cancer is detected, they are always in the very early stages where even a cone biopsy or even a lens biopsy or even a small just a hysterectomy will cure the disease. You all understand? So deaths have become rarer. So that is what you need to understand about the epidemiology of cervical cancer. What is the peak of cervical cancer? Is between 30 and 40 years. It's young, right? So women between 30 and 40 years, that is the peak. Normally it's about 17 per 100,000, right? And then it goes down. And then again, there's a small peak around 80 years of age. So there are two peaks actually. The biggest peak is between 30 and 40, right? And then after about 80 years of age, there's another small peak depending on the epidemiological data which we have. Okay, right. But worldwide, what has happened is, right, the incidence of cervical cancer is there, but in the countries that have a good cervical cancer screening program, cervical cancer has come down drastically. Okay, right. So that is what you need to know about the overall status of cervical cancer in the world. If you look at as to why it happens, the answer is very clear now, right? It is due to human papillomavirus, right? All the other risk factors are very, very small. What are these risk factors? We just need to talk to him. High parity. The more children you have, the chance of cervical cancer goes up, right? The more number of sexual partners the woman has, the incidence also can go up. The intercourse at early, if the age is younger at the time of first intercourse, right? All of these are sort of linked to human papillomavirus. So if the first age at intercourse, if it is younger, the incidence goes up. If the woman smokes, the chance of cervical cancer goes up, right? But all these factors are dwarfed, becomes very small in comparison with HPV infection. All over the world, right? HPV 16 is the most prevalent cause of cervical cancer, along with 18, but 16 is the biggest cause. In some countries like Indonesia, for some reason, HPV 18 is more prevalent than HPV 16. But if you take the whole world, HPV 16 is the commonest human papillomavirus that causes cervical cancer. Okay? And of course, there are other subtypes, and therefore, vaccines are coming out, as you all know. You can have bivalent to 16 and 18, then quadrivalent for 4, 31, 32, 16 and 18, right? And then 6, 8. So those things are already there, where you can vaccinate women who have not had their first sexual intercourse, school-going children, right? Or women who have never had sexual intercourse can be vaccinated against this disease. So as soon as, in Sri Lanka also the vaccination program is there. So as soon as all these are initiated, right, in the future, hopefully, because of vaccination and in combination with the cervical screening program, hopefully the cervical cancers will come down, right? So that is the current status of cervical cancer, which you need to understand. Is that clear, children? Right. Then let's think about how it's detected. Of course, how it's detected is the number one, cervical smear, right? And then if you get malignant cells there and it says that, okay, there is a lesion, then of course, that is one way of diagnosing it. The second way of diagnosis is when you do a speculum examination, you can see the lesion, some macroscopic lesions, right? Remember, stage 1, right, are microscopic lesions, right? And when 1A, right, when it goes to 1B, then the lesion becomes visible. Clear? So these stages are all divided, which I will just discuss, because you don't need to know the small ones, A1, 1A1, 1A2, 1B, right? All these small details you don't need to know as MBBS students, but I will give you the general sort of background on the staging as well. So that is how it's detected. Now, when it's detected, right, the woman might come to you with very late stages, right? And the woman might come to you, or we detect them at very early stages, right? And when they can come with bleeding, backache, if all the parametrium and the side walls are involved, severe pain, they can come with metastasis into distant organs. So those are late stages. And when you do the speculation, you can feel that the cervix, you can see the lesion, and you can see sometimes the vagina is infiltrated right down. It can be infiltrated right down, and where you can see the hardened surface of the vagina, which is infiltrated. When you do vaginal examination, and you cannot feel, sometimes if the parametrium is involved, right, you cannot feel any soft tissue between the cervix and the pelvic side wall. So that is also seems to be invading into the pelvic side wall and the parametrium. So when you do a vaginal examination also, you can feel, initially you can think of the stages as well, right? Now, if you look at all the cervical carcinomas, 85% of them, right, are either squamous cell or adenosquamous cell carcinomas, the mixture, right? So most common are squamous cell carcinomas, as you know. Why? Because the cervix has squamous cell epithelium, right? Then so most of them are squamous cell, because you know that the vagina has squamous cell and it meets the column epithelium at the squamocolumnar junction, right? That is where most of the change and the viruses can infect, because that is the zone where the cells are changing from one to the other. And that is a zone that, because it's very difficult for the virus to invade a mature cell, right? When there is change between one to other in the squamocolumnar junction, the virus can infect very, not easily, but can infect. That is why we find most of the amount of lesions there. So therefore, most of them are either squamous. Now, if you look at squamous, you get large cell keratinizing, right? Then you can get small cell squamous carcinomas, right? And you can get large cell non-keratinizing carcinomas. So that is a normal patho, the different types which we might get. Okay, 85% of them are either squamous or a mixture of squamous and glandular ones, that is adenosquamous carcinomas, right? 85%. 15% of them are what it is? 15% of them are different types, like the cervical glandular type carcinomas, right? These are pure adenocarcinomas. These are from normally the types are, you can get endocervical glandular types, right? You can get endometrioid types, you can get clear cell carcinomas, right? Or a mixture of those, right? And there are different kinds of glandular ones that you can get. What you have to remember, children, the majority, 85%, are either squamous or adenosquamous, the mixture of adenomatous and squamous, like glandular adenosquamous carcinomas, and 15% are adenocarcinomas. Is that clear, children? So that is roughly what you need to remember about the subtypes of these, right? Now, what if you look at the types, right? What determines prognosis, right, of this? What you have to remember is, the bigger the tumor, the more the stage, the prognosis is worse. Okay. Undifferentiated ones, right, the prognosis is worse. If there's more lymphovascular invasion, the prognosis is worse. If the histological subtype is like clear cell, then the histological type, right, and the histological type subtype also, the prognosis can change with that, right? So the earlier the stage, the better. Obviously, the higher the stage, the problematic. More undifferentiated, the prognosis is worse, right? So that is what determines it. But one of the main factors of determining the prognosis is it's whether there is lymphovascular invasion, whether it has gone to the lymph nodes, and whether it has reached the pelvic side wall, right? Those are the factors that we need to consider. One of the most problematic ones are the ones that have reached the pelvic and from there onwards to the para-aortic lymph nodes, right? The higher the stage, what you have to remember is the chances of them reaching the pelvic lymph nodes is higher, and higher the stage, the chances of them reaching the para-aortic lymph nodes are higher. For example, in stage 3, about 30%. Remember 3 and 30, right? Percent of the para-aortic lymph nodes are involved. And in stage 4, about 40% of the para-aortic lymph nodes are involved. As opposed to if it is stage 1, 1A, 1, right? 1A, 1 and 2, right? Almost 0. Maybe 2%, but 1A, 1, 0, right? And if it is, when it comes to about 1B, right, then about 5% of the lymph nodes are involved, right? So therefore, then the pelvic lymph nodes, right? But para-aortic is almost 0, maybe 0.4, 0.6. But that you don't need to remember that. What you have to understand, children, the higher the stage goes, that is from 1 to 2, 2 to 3, 3 to 4, more pelvic lymph nodes are involved, and then of course the higher the stage, the more para-aortic lymph nodes are involved. That causes a worse prognosis because from the para-aortics it can spread to the rest of the body. Is that clear? Right? So that is what you have to generally understand about the epidemiology, right? About how it spreads, right? What are the preventive measures available and how it is diagnosed. Now, once we have a diagnosis or the subtypes which I have spoken about, once it's diagnosed, the most important thing, right? Once you have taken a biopsy and then we have found that this is okay, this is carcinoma, and then we have found the subtype as well by histology. The most important thing that determines treatment is staging, right? So we need to stage the disease, and staging of the disease is of paramount importance. It's the most important thing because treatment is determined by staging. So staging, if you know beforehand what the staging is, then the chances of a correct treatment is very much there. And of course, treatment will need to be discussed among the specialists, the radiologists, the surgeons, right? The gynecological surgeons, right? And as you know, cancer treatment is a subspecialty now in our country as well. There are gynae onco surgeons, right? Who do this day in and day out, right? And in almost all countries where there's a gynecological subspecialty, usually these cancers and immune cancers are referred to these centers. So and therefore, in Sri Lanka, we have several gynecological oncological stations. Maharagama is one. Peradeniya is not Peradeniya. Kandy we have. I'm not really sure about the other stations. I think Kurunegala has. So there are gynecological oncosurgeons that are stationed who deal with these cancers specifically, right? So, which is good because the the more subspecialties that are created, the better the deal is for the patient who is coming with this. But of course, in Sri Lanka, what we have to remember is in other countries, they have not got the rates of cancer down by operating on already existing and late stage carcinomas. Okay, we can only get the stages of cancer down by detecting them early and treating them, specifically by doing a complete cancer cervical screening program. But for that, it requires a huge amount of money, right? So therefore, probably having a complete cancer screening program in our country maybe is not in the near future, where all the women of reproductive age from 25 to 65, right? That is where the cancer screening takes place, right? Is taken into the program. But hopefully we will reach that one day. Right, so getting back, how do we stage children? Staging is done, number one. Of course, clinically what we can do is, once we know the histological subtype, the clinical staging is done by a vaginal examination under anesthesia. So the vaginal examination can be done, and mainly because the whole pelvis is relaxed, the main criteria is to check whether the parametrium is involved, which you can feel with your finger, and whether it reaches the pelvic side wall, right? When you do the vaginal examination, you feel between the cervix and the pelvic side wall, and you feel the parameter to see whether it is hardened, right? And whether it is reaching there. However, and of course, we need to do a cystoscopy to check whether the bladder mucosa is involved in that, and maybe a sigmoidoscopy. So you can do a staging like that, right? However, for proper staging, of course, now there are tools which we use. What are these? So clinical examination alone, right, is not sufficient now for staging. Of course, you can get a certain amount of information, but you can get more information if we use the other tools of management. What are these? These are MRI. So MRI can show us the cervical lesion, extension into the lymphovascular space, spread down into the vagina, and whether it reaches the pelvic side walls. And then it can also look at the pelvic and the para-aortic lymph nodes, right? A CT will also help us with that, right? But MRI, and sometimes in some centers, a PET scan, right, can also be used. A full body PET scan can be used to look for distant lesions as well, right? So taking all this into consideration, if you are looking at the lymph nodes, of course, you can also do a CT, but an MRI will give us a more clear view as to the spread of the disease. So using, yes, vaginal examination, clinical examination, you can do cystoscopy if you want, you can do sigmoidoscopy, rectosigmoidoscopy if you want. But if you do an MRI along with that, right, a CT can be used, or even ultrasound can be used to check for the para-aortic and the pelvic lymph nodes. Taking all this in conjunction, you can form a very good idea, especially if MRI is included, as to the stage of the disease. You all understand, children? So when we know the stage will determine your mode of treatment, right? And now if you roughly look at the stages, children, now the stage is done according to the FIGO classification, and that takes into account its physical spread into the surrounding tissues, into the parametrium and the pelvic side walls, spread into the lymph nodes, and spread into the vagina. Okay, so those are the ones that you need to understand. Now, if you look at stage 1 as a whole, right, there's 1A and 1B, right, it is confined to the cervix. Okay, that is what you need to understand. But of course, there's a division of 1A1 and 1A2, right? And then you go on to 1B. Okay. Now, 1A1, basically 1A1 is a stage which is diagnosed later. You take a biopsy and suddenly they say, okay, now the invasion is there, but it is less than 3 millimeters. So that is 1A1. Between 3 and 5, it is 1A2, right? In depth of invasion. But so that is all diagnosed later, right? So if you take a cone biopsy or a lens biopsy, and then the histology comes, and if the histology says that the whole lesion is included, the resection margins are clear, right? That consists of a cure. So you don't need to do anything much, right? However, if the resection margins are not clear, but still if the stage is the 1A1 or 1A2, right, or 1, then of course a simple hysterectomy is enough. Okay. The problem with 1B, right, is that the depth of inflammation is slightly more. So the so the depth of inflammation is slightly more. Now, when it comes to that stage, right, what has happened is, 1A, when that happens is the pelvic lymph nodes can be involved if the depth of inflammation is more than 5 millimeters. Okay. Sometimes in stage 1, the pelvic lymph nodes are involved. So in those cases, you might need to combine that with a pelvic lymph node removal as well. Am I making myself clear? In the initial stages, if the depth of inflammation is not too much, children, just remember, right? Don't worry about the figures. What happens is the chance of pelvic lymph nodes getting involved or the para-aortic lymph nodes getting involved is almost zero. So therefore, just a cone biopsy or a simple hysterectomy can sort out the problem, right? However, if the depth of inflammation is slightly high, right, or larger, right, more than 5 millimeters, okay, then, but less than stage 1B, okay, because 1B is already a lesion that you can see. Remember, I said 1A, right, is a stage where you cannot see with the naked eye. It's a microscopic diagnosis. 1B, already the lesion is visible, okay, right? So therefore, when you look at that, 1A, sometimes the depth of, if the depth of inflammation is up to 5 millimeters, right? Sorry, I think there's a small confusion. Let me just say, right? Let me just go back. Right. If it's stage 1A, okay, the whole thing is confined to the cervix. Is that clear? Right. When there is stage 1A1, the depth of invasion is very small, right? Sometimes less than 1 millimeter, right? Then the stage 1A2, then the depth of invasion is between 1 and 3, okay? And then stage 1A2, then if the 1A1 is up to 3, 3 to 5 is A2, more than 5 millimeters, depth of invasion more than 5 millimeters, or visible lesions will be 1B, okay? So in this, if the depth of invasion is more than 3 millimeters, sometimes the lymph node involvement may be there. So those ones can be combined with a pelvic lymphadenectomy. So basically what you need to remember is, children, stage 1, it can be either, when we do the cone biopsy, it may be a cure, or you might need to do a hysterectomy, a simple hysterectomy. And sometimes in stage 1A2, right, because there is a chance that the lymph nodes may be involved, pelvic lymph nodes, you might need to combine it with the pelvic lymphadenectomy as well. Is that clear? Right? So don't worry about the millimeters, you just remember that. So the treatment would mean either LETs or a cone biopsy, and if the margins are clear, that is all. If the margins are not clear, you can proceed to a simple hysterectomy. And in later stages like 1A2, where the depth of invasion may be slightly high between 3 and 5. In those cases, because the pelvic lymph nodes may be involved, you might require to do a pelvic lymph node dissection as well. So that is the treatment for this disease. Okay. Overall, the survival rates are very high and the cure rates are good. Is that clear? Then you get to 1B. Now 1B is the clinical lesion is seen. You can see it with the naked eye. Okay. And the depth of invasion is more than 5 millimeters. Right. So anything more than depth of invasion 5 millimeters up to lesions which you can see, but confined to the cervix, right, is 1B. Now from there onwards, right, then you go to stage 2. Now stage 2 is what has happened is the lesion has gone down into the vagina, but it doesn't go down very much, just the upper vagina, maybe the upper two-thirds of the vagina, right? And but up to 2A, from 1B to 2A, there is no parametrial involvement. You all understand, children, right? There is no parametrial involvement, and definitely it has not reached the pelvic side wall, and it has only invaded up to about 2/3 of the vagina. This is the place where we can do surgery. Okay, from about 1B to 2A, and the surgery is a radical hysterectomy. That is all you need to know. What is a radical hysterectomy? You remove the uterus, right? You remove the parametrium that may have micro lymphovascular invasion, right? The parametrium surrounding the cervix. You remove the parts of the vagina which may be involved, right? And then you do the pelvic lymph node dissection, right, as well. And if the MRI or the CT shows para-aortic lymph node dissection, right, then of course you remove those as well. Or you can just leave the para-aortic lymph nodes and give radiotherapy later on. Is that clear? But this is the place from 1B. Remember, 1B are macroscopic lesions confined to the cervix, but cervix, right? Or anything greater than 1A2. Anything the 1A2 is the depth is more than 5 millimeters, right? Depth is less than 5 millimeters. Anything more than 1A2, but or visible lesions up to 2A, where there is no parametrial involvement, right? No parametrial involvement, confined to the cervix, but it can be invading the vagina. You can do surgery. And what is the surgery, children? Is radical hysterectomy. So if you remember that, that is all. What is radical hysterectomy? You remove the cervix, you remove the uterus, you remove if you can remove the you remove the ovaries, fallopian tubes, right? And then you remove the parametrium around it, because there may be microvascular invasion, right? And then you remove the pelvic lymph nodes, and in different subtypes, if the subtypes are more undifferentiated, you can go for the para-aortic as well. Is that clear? Then comes after 2A comes 2B. And what does 2B means? There is parametrial involvement. Okay. When there is parametrial involvement, from 2B onwards, surgery is not really possible, because you can do surgery, but it's not really feasible, because at that point, radiotherapy is more effective than surgery, because since there's parametrial involvement, then of course it goes on to the pelvic side walls, right? And then it can also go down and involve the lower 1/3 of the vagina as well, right? When that happens, of course, surgery is not possible. Surgery will be very much traumatic. So therefore, what can be done is you can do radiotherapy. So if you understand, right, up to 1A, stage 1, you can do surgery, right? Then stage 1B to 2A is radical hysterectomy, okay? And then from there onwards, right, so 2A, 1B to 2A, and from 2B, which means parametrial involvement, from there onwards, it is normally radiotherapy. Is that clear, children? So the higher it goes, so the more. Stage 3, if it goes to stage 3, and then stage 4. Now stage 3 would mean what? The pelvic side walls are involved. Stage 4 would means bladder, rectum, and distal metastasis, right? All these stages, right, you will have to give either radiotherapy. And what are the types of radiotherapy that are there? There's something called teletherapy, right, which is given from over the tummy and directly into the pelvis or the paraortic lymph nodes, right? And brachytherapy, which is given through the vagina. Okay, so those are the types of radiotherapy which are directed at the tumor and whatever is left at the parametrium, the lymph nodes, that can be directed. And then there is also possibility of giving cisplatin based chemotherapy as well, right? So that is chemotherapy is also a possibility when at the later stages. And then of course there is chemoradiation. You can combine chemotherapy with radiotherapy, which is called chemoradiation. So the options are, remember, just radiotherapy, which is teletherapy and brachytherapy. That is all you need to know. Then there is chemotherapy, usually cisplatin based chemotherapy, right? And then there is the combination of these two, which are called chemoradiation. So if you know these or understand this, you don't need to really know the small details of what is given when, right? So that is done by specialists, especially oncologists, right? And radio oncologists, all of them get together and they decide as to how it's given, right? But these are the options that are available for treatment for the later stages. And of course, then palliative surgeries are there for when at the very, very late stages where palliation is needed. Is that clear? Right. Then for recurrence, if there is recurrence of cervical cancer, right? If the woman has got radiotherapy earlier, right, then she can be tried with chemotherapy. If the woman has got chemotherapy, then radiotherapy can be tried. If the woman has got surgery earlier, either radiotherapy or chemotherapy or chemoradiation can be tried. So that is the general principle that you need to understand, right? And the other type of surgery, especially for central recurrences, if recurrences are in the middle, right, central, you can take the whole bladder out if the bladder is involved, right? And that is radical, very radical surgery. Or you can take the whole bladder and, if necessary, resect the rectosigmoid and then put diversions so that the whole pelvis is, organs of the pelvis is removed, right? So those surgeries, radical surgeries, are also possible for very late stage, especially for recurrences of patients who have already been operated or given radio chemotherapy earlier for disease. Do you all understand? Right? So these are the things you need to understand about cervical cancer. So if we again, generally for you all to understand, please look at the FIGO classification, which will give you the specific stages, but you really don't need to know all the specific stages, right? What you definitely need to know are what are these. Stage 1 is confined to the cervix. Clear? Stage 2, right, is confined to cervix, but it grows onto the vagina. But there is no parametrial involvement, right? But stage, when it comes to stage 2B, right, then already we have parametrial involvement. Stage 3, it grows down to the lower 1/3 of the vagina, okay, right? And it go up, there is parametrial involvement. And stage 4, it grows to the bladder and the rectum and the distal metastasis. So that is what you need to understand on the stage. If you look at treatment, it is simple, right? From 1A1, which is less than 3 millimeters of invasion, right, into the cervix. 1A2, which is less than between 3 and 5 millimeters of invasion, right? These stages can be treated with LETs or cone biopsy. And if the margins are clear, that is all. However, the margins are not clear, then you have to go for a hysterectomy. But those, there can be fertility spare, the ovaries can be left without taking them off. Is that clear? When it goes to beyond that, where the depth of invasion is more than 5 millimeters, or there's a visible lesion, which is so it becomes 1B, then of course, surgery is required, and then the surgery is what? Radical hysterectomy. And radical hysterectomy can be done up to 2A, because 2A does not have parametrial invasion. Okay, so no parametrial invasion up to that is 2A. So lesions can be up to about more than even 4 centimeters large, and the vagina also can be infiltrated up to the upper 2/3 of the vagina. Okay, for that, radical hysterectomy can be performed. So there are different stages of radical hysterectomy, but remember 1B to 2A radical hysterectomy. Is that clear? Anything over that, 2B, because there's parametric involvement, and above is either radiotherapy, right, or chemotherapy or chemoradiation, right? And then radical palliative surgeries, right? Removal of the bladder or removal of the rectus sigmoid and creating diversions, right? So those are the things that are available for the treatment of these patients. The higher the stage, the more para-aortic lymph nodes are involved, the lesser the chance of survival for the woman, right? So those are the principles of treatment of cervical cancer, which you should know about. Okay, right. That is all I wanted to tell you all, because you will not be questioned much or in depth about these things, but these are the principles that you need to be aware when you are talking about cervical cancer. Okay. Anything else that you want to know? Any questions? Yes, any questions? Yes. So what you need to do is just look at the FICO classification. For yourself, what you do is just on this side, write the FICO classification, and then on the other side, just write the treatment options. So at a glance, you understand what can be treated with what, right? And then that is easy for you to remember. Okay? Right? So then we'll, what is the next topic that you all want me to do? Nimsar, you told me something, right? Okay, I have a question. In Sri Lanka, what is the age for screening? All over the world, the age for screening is from 25 years to 65 years of age. When the what is this age is less than 25, the chance of cervical cancer is very, very small. So therefore, there's it has been found that there is no point in what is this? No point in screening below 25 years of age, right? So right. So any more questions? There's another question, right? One moment. Can you explain about fertility sparing surgery? I forgot about that. For cervical cancer, and up to which stage we can do that. Now, fertility sparing surgery, right? Right, okay. I forgot to speak about that, right? Fertility sparing surgery is when the woman has not now. Remember, the peak of cervical cancer is between 30 and 40, and this is the time when women want to have children, right? So fertility sparing surgery is possible, especially in the very early stages, right? In which case, radical trachelectomy can be performed, right? Where the cervix along with the parametrium is removed, right? So in which case, however, if the woman, once the woman has children, then of course, the complete surgery is indicated because you do not take a risk of leaving it there, okay? So one of the options which you need to understand in the early stages, and if fertility sparing surgery is required, so you keep the uterus, but you remove the cervix along with the parametrium, which is called trachelectomy. Earlier, yes, trachelectomy can perform both abdominally and vaginally. Abdominally, the advantages of performing a trachelectomy is you can do the lymph node, either the biopsy or the lymph node removal, while from below you can remove the cervix. So you can combine it with an abdominal as well as you can do a vaginal surgery as well, right? So that is trachelectomy, and it's called a fertility sparing surgery. So if you ask a question as MBBS students, okay, what is the fertility sparing surgery called? Then you say call it remember a trachelectomy, which you need to know. The other thing which I wanted to tell you about cervical cancer is the higher the stages, what happens is the metastasis comes and it can spread all over the country, and as it spreads onto the pelvic side walls, and then the ureters get blocked because ureters go very close to the cervix, and then the woman develops hydroureter hydronephrosis, right? By that time, the huge amount of pain will be there, and those are the terminal stages where they grow into the pelvic side walls and where they involve this. The most amount of pain the women have is when the cervical cancer grows onto the lumbosacral trunks, right? It's very the symptoms are extremely severe, and it's very difficult to control the pain symptoms where when they invade the lumbosacral trunks, right? So those are the ones which in the later stages which you need to remember that can give a lot of pain. Okay, that is all, I think. Are there any other questions? I remembered something, then now I can't remember what I want to tell you about. Something else which I want, but now I can't remember. Okay, anything else? Any other questions about cervical cancer? So I've spoken to you about the epidemiology, the etiology as to what it happens. I have spoken to you about how it spreads. I have spoken to you about the staging, how we do the staging, right? I have spoken to you about the treatment options which you need to know roughly, right? If you remember, just for you all to remember, 1A, stage 1 up to 1A, stage 1 up to 1A, 2, it is cone, LEDs or hysterectomy, right? In 1A, 2, when the depth of invasion between 3 and 5, sometimes you might need to do a pelvic lymph node biopsy because because it might be about 5%. But if it is 1B to 2A, it is radical hysterectomy, and then 2B and above, because the parameter is radiotherapy. Okay, so that is roughly what you need to know about. And the radical types of radical surgery also, you need to know removal of the bladder, removal of the rectus sigmoid with dilations. All right. Okay, and the fertility sparing surgery is called trachelectomy. Okay. If a patient found to have cervical cancer of stage 2B while she's pregnant, should we terminate the pregnancy and start on radiotherapy? That is a very difficult decision. Now, as you understand, 2B is parametrium involved, right? So, parametrium is so radiotherapy is the treatment of choice. What I want to tell you is, even at the earlier stages, before we get to that question, let me tell you what I want to tell you. I just remembered. Earlier stages are also can be treated by radiotherapy. Okay, and they are very effective, very, very effective. So the treatment success rates are almost similar in the very early stages, right? Right, that is 1 and 1B, right? Even so, even the treatment rates of radical hysterectomy in the early stages, if you give radiotherapy, it's the same. But the difference is surgery in these stages have definitive advantages over radiotherapy. What are these? Number one, fertility sparing. If you can leave the, not the fertility, you can leave the ovaries, or it can be a fertility sparing surgery, right? You can leave the ovaries, which is a great advantage, because when you give radiotherapy, the ovaries will be affected. Second thing is, radiotherapy can cause a lot of dysfunction, right, of the bladder, right, and the bowel, right, and the vagina also can be affected, and fistula can be formed, right? So those things, there are a lot of disadvantages, because radiotherapy can cause a lot of disruption of the pelvic organs that are left, right? In surgery, that is avoided. In very good surgeons, right, when the surgery is done, the chance of these complications are very small. Of course, when the parametrium is excised in radical hysterectomies, you can have dysfunctions because the bladder and the bowel dysfunctions, because we are taking off the parasympathetic, and the sometimes if it is not nerve sparing, the innervation of the bladder and the rectum can be disturbed, and of course you can have dysfunction. But radiotherapy can give more problems of affecting these organs. So therefore, surgery in these very early stages may have some advantages over radiotherapy alone, right? So that you have to remember. And what are these radiotherapy problems with radiotherapy? Because the epithelium gets destroyed, you can fistula can form, bladder dysfunctions can happen, and bowel dysfunctions can happen. They can have diarrhea, sometimes constipation, sometimes fistula formation. So all those problems, tissue healing is bad. So all these problems can occur with radiotherapy, right? Okay. What is the question? I forgot. If a patient found to have cervical cancer at stage 2B while she is pregnant, should we terminate the pregnancy and start on chemotherapy? If the baby is possible to survive, right? Yes. Then you take the baby out, right? And then you start on radiotherapy. If the baby is very preterm and you not be able to survive outside, then that decision needs to be taken in conjunction with everyone. Surgeons, radiologists, and then you need to stage, and the parents, right? So an expert panel will need to discuss this, whether it is possible to wait until the baby is viable to take it out and then commence on radiotherapy, right? So terminating a very early pregnancy, sometimes the decision is slightly easy, say if you, but at 28 weeks, as mentioned here, the baby is viable actually. With very good support, the baby can. But sometimes the expert panel will decide, okay, let's wait till about 30 weeks, another 2 weeks, right? Or 32 weeks, another 4 weeks, and then take the baby out and start on radiotherapy. You all understand? So that decision is, it's not a, there's nothing written about, okay, 28 weeks we do this, 26 weeks we do this, nothing like that, right? So it will be decided in a multidisciplinary manner as to what to do about the pregnancy. But generally, the principle is the baby is viable, right? You can keep it in viable, you take it out and give it away. If it's not viable, then you have to take the decision whether we can wait until it's viable, deliver, and then give radiotherapy. You all understand? So the answer is not very clear cut on that. Okay? Right. Any other questions, children? Yeah. Okay. What is the topic you all want me to discuss next time? Nimsara?
So subfertility.
Subfertility. Okay. Subfertility. Is everybody agreeing to that or what? Any other suggestions? Okay, subfertility is one topic. Observe guide next time. Subfertility. Okay. So we'll discuss subfertility because it's a common sort of case, right? So remember, you will, when you all are getting cases, yes, you can get a case with subfertility. But when you all are getting questions, you are not going to get a whole question on just subfertility. It will be an aspect of subfertility, right? When you are getting written questions, it will be on one aspect of infertility which you will be getting, right? Describe subfertility, have a question, right? So, but the case, of course, can be a patient with infertility. So, yes, okay, we'll discuss that. Maybe we need to discuss it in 1 or 2 days, but we'll see how it goes. So, we'll do infertility. Fine. Okay. Okay, then. Since there are no questions, then we will sign off. Okay. Good night.
Thank you, sir. Good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.